Hi, I am Riza Tila Cambra, a fourth-year dental student of Misamis University, and for this video, I am going to show to you or discuss to you about my impacted case presentation. And before anything else, let us first discuss my patient's data. She is Mency Pisa Clagon. She is 23 years old and is currently living in Dato Tutukan, Dumingag, Zamboanga del Sur. She is female and she weighs 50 kilograms and her height is 5'2", and the tooth that we are going to perform the surgery on and the impacted tooth is the tooth 3/8. And before anything else, before we jump to the pre-operative evaluation, let us talk first why we need to do preoperative evaluation. That is because many patients present medical conditions that affect the wound healing and their ability to tolerate the oral and the maxillofacial surgery, and also preventing medical conditions or the medical emergencies in the patient undergoing these kind of surgeries is always easier and better than managing emergencies once they occur. That is why the dental healthcare provider must discover the presence or history of medical conditions that may affect the safe delivery of care, as well as any conditions specifically affecting the oral and the maxillofacial region. And now, let me share to you the preoperative evaluation I did on my patient. So for the case history, the patient started noticing that her 3/8 is an impacted tooth or an impacted case a year ago, and she felt pain and discomfort during the month of February this year 2020. And for the medical history, the disease prevalent in the family is hypertension. The cause of death is the natural death, and the disease during childhood is just the common cough and colds. Lungs are normal, heart is normal, and the blood pressure is 120/80 mmHg, and her menstruation is irregular. For the extraoral examination, there are no signs of redness or swelling on the cheeks. There are no signs of trismus during the mouth opening, and there is no paresthesia on the lower lip. For the intraoral examination, there is an adequate access upon opening of the mouth. There is no signs of pericoronitis, and the adjacent tooth 3/7 and 3/6 are both present and are vital tooth. For the radiographic interpretation, let me show to you her radiograph of the tooth. This is it. I am sorry. Wait. Oh, that is the x-ray. And as you can see, the type of impaction that she have is a horizontal impaction with class 2 Ramos relationship and class A depth. Class 2 because the distance, as you can see here, wait, on the radiograph, class 2 because the distance between the second molar and the anterior border of the ramus is less, and the existing space is less than the mesiodistal diameter of the crown of the impacted tooth, and it is a class A depth because the occlusal surface of the impacted tooth, as you can see here, is at the same level as or a little below that of the second molar. And the base of the root, we have two roots here, and it is important to know the root morphology of your impacted tooth, so because this plays a major role in determining the degree of the difficulty in the removal of the impacted teeth, and this will also guide you or give you a better understanding on the tooth that you are going to perform surgery with. And the tooth is partial bony impaction. This means that the tooth has partially erupted, as you can see, but a portion of the crown remains submerged below the gum and surrounding jawbone. The tooth is therefore embedded, and the lamina dura of the mesial surface, I am so sorry. The lamina dura of the mesial surface of tooth 3/8 it has expanded. And for the Winters lines, we are basing here. For the white line, this corresponds to the occlusal plane, which indicates the difference in occlusal level of second and third molar. The amber line or the yellow line that you can see there represents the bone level. This denotes the alveolar bone covering the impacted tooth, and the red line here represents the depth of the tooth in bone, and then difficulty encountered in removing the tooth. This indicates the amount of bone that has to be removed before the elevation. Here, the red line here, this one. And these classification systems are mutually exclusive, and when used together are not mutually exclusive, but when they are used together, these can aid the surgeon in assessing difficulty and the extent of surgery, and also to plan a surgical approach for patients with impacted mandibular third molars. And again, our diagnosis for this tooth is a horizontal impaction with class 2 Ramos relationship and class A depth. And the preoperative care and medication that we are going to give to our patient is let the patient sleep for a few days before the surgery, and there should be no alcohol intake few days before the surgery, because these things may affect the onset and the duration of anesthesia to the patient. Another one is advise the patient to take proper diet and water intake a week before the surgery. And let the patient take the medication co-amoxiclav or Augmentin 625 milligrams tablet twice a day for 3 days before the surgery. Why? Because when this is administered just before or after the surgery, this reduces the risk of infection, pain, and dry socket after wisdom teeth are removed by the surgeon. And also, another medication that the patient should take before the surgery is the transamic acid or the Hemostan 500 milligram capsule 24 hours before the surgery. The transamic acid works by slowing down the breakdown of blood clots, which helps to prevent prolonged bleeding. And of course, the very important part that you are going to prepare for the surgery is the armamentarium or the materials. And the basic instruments, of course, that which we uses every day in our clinical setup is we have the mouth mirror, the explorer, the cotton plier, the periodontal probe, and the soft tissue retractors. We have the Minnesota retractor and the gum separator. For the hard tissue instruments, we have the bone files, the bone wronger, surgical burr, which is round, fissure, and straight burr. We have the high-speed handpiece and the Adson forceps. And also the elevators. Excuse me for a while. The elevators that we are going to use during this surgery is the elevator number 301, Cryer elevator, the Molt periosteal elevator, the Cogswell elevator, as well as the Selden periosteal elevator number 23. The extracting forceps that we are going to use is the number 44 extracting forceps. The incising instruments is the number 15 surgical blade, as well as a scalpel handle. The suturing instruments or the materials are the suturing needle, the suturing thread or which is soluble, the number 15 surgical blade, scalpel handle, surgical scissors, hemostat, needle holder, the Holstead mosquito forceps, as well as the Alice forceps. And of course, the miscellaneous armamentarium, we have the scrub suit, mask, head cups, sterile gloves, the dental syringe needle, the anesthetic solutions, which is the lidocaine, the drape for the patient, oral betadine, mouth prop, cotton balls or rolls, topical anesthesia, suction tube, saliva ejector, normal saline solution. We have also distilled water, the 10 ml disposable syringe for irrigation, towel, bib, towel clips and bib clips, of course, and the enamel tray and the cotton gauze. And for the pre-procedure preparation that we are going to make is let the patient first gargle oral betadine solution. This reduces bacteria levels in the patient's blood after the procedure, and this is based on the Turkish study findings. And the cleaning solutions, or you may use alcohol or NSS, used on skin to remove residual soap solution. And also, again, the last thing is to drape your patient. Now, the purpose for draping your patient is to create a maintain a sterile field during a surgical procedure, and also to eliminate the passage of microorganisms between the non-sterile and the sterile areas. And during the surgical procedure, of course, we are first going to anesthetize the patient. We are going to first dry the mucosa and apply the topical anesthesia on the site of surgery, and then administer the local anesthesia using the mandibular nerve block technique or the GO gates. And the nerve or areas that we are going to anesthetize is all the mandibular nerve and its subdivisions, including the inferior alveolar nerve, the lingual, buccinator, mylohyoid, and auriculotemporal nerves. Also, all the mandibular hard and soft tissue to the midline, including the floor of the mouth and anterior 2/3 of the tongue, the lingual soft tissue and periosteum, the posterior portion of the cheek and the temporal region, and a portion of the external ear. And to safely anesthetize our patient and to guide us which area is to put your needle in, we have these anatomical landmarks that we are going to use. We have the anterior border of the ramus, we have tendon of the temporal muscle, corner of the mouth, intertragic notch of the ear, and the external ear. Okay, for the needle pathway during insertion, the patient's mouth is wide open and the needle is inserted at a point lateral to the pterygomandibular depression but medial to the temporal tendon on a plane from corner of the mouth to the intertragic notch. And the approximating structures when needle is in position is, when needle is in its final position, it should be just inferior to the condyle itself and inferior to the attachment of the lateral pterygoid muscle. Place the patient in a supine position and the operator is positioned to the right and slightly in front of the patient. Patient keeps the mouth widely open and remains in that position until injection is completed. This position moves the condyle anteriorly, thus facilitating the notch of the ear. The anterior border ramus is palpated and the tendon of the temporal muscle is identified. Operator visually aligns the intraoral and the extraoral landmarks, and the needle is introduced through the mucosa just medial to the temporal tendon and directed toward the target area on a line extending from the corner of the mouth to the intertragic notch. The degree of divergence of the external ear to the head is used as a guide to the lateral flare of the ramus, and the needle insertion should be parallel to the degree of the flare of the ear. The needle should be advanced until the fovea region of the condylar neck is contacted, and the depth of insertion should not exceed 2.5 to 25 to 27 millimeters. If bone contact is established, the needle should be withdrawn slightly and redirected after checking landmarks. The entire contents of the dental cartridges should be injected only after establishing proper needle placement, for example, bone contact. After withdrawing the needle, the patient is to keep the mouth open for 20 to 30 seconds to allow adequate bathing of the nerve trunk that has been straightened by opening of the mouth. And because of the large diameter of a nerve trunk and distance from injection, which is approximately about 1 centimeters, onset of anesthesia will occur in 5 to 7 minutes. A wave-like pattern of anesthesia starts in the ramus and progresses steadily forward to include the molars, the premolars, and the anterior teeth in sequence. The adequacy of the anesthesia may be demonstrated by a tingling and numbness in the areas innervated by the mandibular nerve and its subdivision, as well as by the absence of pain on instrumentation. Okay, so after anesthetizing the patient, the next thing that we are going to do is to incise, to make a flap design. And our flap design is, incision should be away from the surgical site, should not be on vital structure, should be in full thickness, and it should be perpendicular to tissue, and it should not be made over a bony eminence. Corners of the flap should be rounded. The base of the flap should be wider than the free margin. Why? Because broader than the free margin to preserve an adequate blood supply. This means that all areas of the flap must have a source of uninterrupted vasculature to prevent ischemic necrosis of the entire flap or portions of it. And using the number 15 blade and scalpel, incision of full thickness run from the ramus area for posterior extension. The posterior extension should diverge laterally to avoid lingual nerve injury. The anterior incision of the flap extends from the mesial aspect of second molar running at 45-degree angle extend to the mucobuccal fold. Reflect the incision laterally to expose the underlying bone covering the impacted third molar. This is also, we should be reminded that this should be completed with gentle, steady strokes toward the labial or the buccal vestibule without damaging the tissues, so as to prevent any additional trauma to the tissues that we are working on. A Minnesota retractor is then used, placed just lateral to the external oblique ridge and stabilized against the lateral surface of the mandible and held by a few fingers at its distal end. The second principle that I read in a book, that a firm, continuous stroke should be used when incising. Why? Repeated tentative strokes increase both amount of the damaged tissue within a wound and the amount of bleeding, and we don't want that to happen, thereby impairing wound healing. Long continuous strokes are preferred to short, interrupted ones, therefore to avoid unintentionally cutting large vessels or nerves. The surgeon must incise only deeply enough to find or to define this next layer. Vessels can be more easily controlled before they are completely divided, and important nerves can usually be freed from adjacent tissue and retracted away from the area to be anesthetized. The incision for this type of flap begins at the interior border of the ramus, external oblique ridge. Here, let me show you first the picture of the flap that we are going to make for a second. Okay, so this is the type of flap that we are going to make. This one. With special care for the lingual nerve, and the incision may continue along the cervical line of the last tooth, while the vertical incision begins at the distal aspect of the first molar. Okay, so that is the type of the flap that we are going to make. And, or the incision rather. Okay. For the burr removal, the burr technique buccal and distal bone removal is performed down the cervical line of the impaction. Here. As you can see in the picture, the red thingy in there. This bone removal should be in the form of a thorough, and should not involve the full thickness of the lateral cortical plate of the mandible. Only enough buccal cortical bone should be removed as is needed for access for elevating, sectioning, and purchase point placement. The burr is used in sweeping motion around the occlusal, buccal, and distal aspect of the crown to expose it. Once the crown has been located, the buccal surface of the tooth is exposed with the burr to the cervical level of the crown, and a buccal trough or gutter is created. Continuous irrigation with normal saline to remove debris, avoid overheating due to constant friction. And because when bone is cut,